Hi, everybody. This is Erica Mello and Susan Clinton, and welcome to episode number 155. And yeah, in this episode, Susan and I talk generally, I'm using a patient of mine as an example, but we want to talk about sort of thoracic and lumbar spine bracing patterns. And I'm going to use a patient of mine who actually is a weightlifter, and he also pole dances. And his main strategy was a significant gripping that caused him some excess pain for some years now. And we want to talk about just a little bit about how you would position the patient and how you would teach the patient to sort of take that strategy out of their everyday life or their activities, and you want to sort of down train that strategy. So that is the episode. And Susan, we want to just talk about the website a little bit, right? Our if you have not listened to the our podcast, welcome. Our website is toughtotreat.com, and we have a search function up there where if you haven't listened to us and you want, have podcasts on low back pain or incontinence or leaking or shoulder pain, type those words into the search function on our website, toughtotreat.com, and all the episodes with those keywords will come up. And we hope you enjoy it. I think that's it, Susan, right?
That's it. Enjoy the episode.
Hi, everybody. This is Erica Mello and Susan Clinton. Welcome to episode 155. How are you, Susan?
I'm good. How are you?
I am good. Oh, just bemoaning the lack of snow here in New York, and we're not getting any anytime soon.
And the Midwest we've gotten more than our share in the Midwest. So, and I know the West Coast has had a ton.
I know.
So, every year a little different. Anyway,
when you don't, yes, and you realize. No, I'm saying you realize you missed something when you don't have it. Right?
Yeah, absolutely. So this is episode number 155, and it is also the 1st of April, as most of you all are already probably in spring. We still have about a foot of snow on the ground, but the spring melt is on its way here where I am, and so we're going to just talk about gripping of the spine, or the muscles around the spine over gripping, right?
Yes.
All right.
We have butt grippers, chest grippers, etc. So I'm not going to give you the whole history of this patient because I want to sort of get to the meat of the episode, but I will give you some background. Probably early 30s, late 20s, has a sort of a desk job here in New York City, was complaining of actually low back pain, right-sided low back pain. And it really was worse doing a rack squat in the gym. So when he takes the rack, brings it back, starts to grip, and he squats. That's sort of what that was his sort of his meaningful activity. He also said that he also does pole dancing, and he felt that his hamstrings were really stiff, and he was going through a stretching program. I said, "Oh, you're a pole dancer as well, and you have tight hamstrings. How do you get your legs above? How do you do your moves on the pole?" And he's like, "Well, I do." And I'm thinking, well, he's like, "I often feel after I'm on doing that, my back hurts as well." I'm like, okay, well, that would make sense. So, no other insidious onset of low back pain. I would not say insidious, but in 2013, where he just basically did a move, lifted something up very heavy in the back, has been bothering him on and off since. Okay. Mm-hmm. Also some asthma in the history, and he started doing a lot of heavy lifting in the gym. Does not do upper extremity, which I found interesting. Mm-hmm. Which needs to get remedied. And also when he was doing those glute kickbacks, sort of like all fours butt kicks, the back bothered him as well. Okay, so it was primarily the rack squats, but when he was in the gym, it was the glutes as well. No other significant history. The asthma has been around for a long time, and so did about 225 pounds on the rack squat. Deadlift 90 pounds was fine. I don't find that people who do deadlifts are generally pretty okay. I mean, not everybody, but it's people who have a problem squatting can deadlift. Okay, at least for some of the patients I've seen, I think it's interesting, right? Okay, so the reason I mentioned him is I wanted to talk about his gripping strategy. And so we talk about our magnet board, right? And so for me, on the magnet board of the areas that I thought were meaningful or important to assess, number one, the thorax, because of his asthma.
100%. I have that marked down and starred. It's like,
Yes,
okay, that's a
exactly.
significant piece there.
Yes, exactly. His lumbar spine, just because it's meaningful to him. And then I also have, he didn't really have anything. I'm such a foot person. He didn't really have anything in the history with regards to his with like his knee or his feet. But I'm always suspicious because when I saw him stand, his right foot was very turned out. He was offloading his right side. And so I said, I'll put that low on the priority list, but it was there. Okay. Because it's not meaningful to him. So I actually had his thorax and his lumbar spine, on the magnet board, the top two for me, and maybe a bit of the pelvis, but just because of hamstring tightness and things like that. But I didn't think anything was there with the pelvis. So I'm not going to sort of talk about how I sort of evaluated him because I want to get to his strategy. So I told him how I had a broom in the office, and I said, just to pretend this is like 200 pounds. And I said, just show me how you would, you go under the rack, and then you would take the bar, and then you would, do the rack squat. And most weightlifters are taught to dump, retract and dump that to keep the weight on top of their shoulders. That is a common cue. But with him, it was a cue and a movement strategy he did every time. And he sat for a living. So he'd sit like this, although he doesn't have a problem sitting. It's whenever he does the squat, specifically the rack squat. But when I had him do other activities, just, like a wall push-up or just a reach and like a pick up and lift or any kind of just general movement without weight, he would brace his scapula. Okay. And I've seen that time and time again with people. So I wanted to talk about him because his thorax is his main driver. Okay. Yeah. Basically his thorax is his primary driver. However, I wanted to debunk his whole hamstring thing. So I had him in supine, and I just said, I did a passive straight leg raise, just literally passive straight leg raise. I checked it in 90-90. Yeah, it was okay stiff. He wasn't crazy, but he thought he was very stiff. I said, okay, show me how you would lift your legs if you're on a pole. He started to do the bilateral. I said, no, let's don't do bilateral, double straight leg raise. Just do an active straight leg raise. And he brought it up to like, I want to say 70, maybe 70 degrees, equal. And he's like, see, I'm very stiff. I'm very stiff. I said, okay. So I ended up going into his thorax. I just did some decompression in supine on the table. I had to take a couple deep breaths. I said, do your active straight leg raise now. And it went past 90. He was like, and that, Susan, got a wow out of him.
Yeah.
And he's like,
absolutely.
I'm not really, right? And he's like, oh, I'm not stiff. I'm like, not really. I mean, you're not stiff. I said, the stretching program you can do, I just don't think it's a good use of your time. So I mentioned that because he was just like, oh my God, I can't believe this. I've been doing the stretching and it's not helping. I'm like, I said, it's helping, but it's not your driver.
So when he was laying on his back and doing the active straight leg raise, did he squinch his scapulas together and stick his chin out?
Yeah, exactly.
Did he have headaches or anything else?
No.
Because one of the other things I see with this pattern is that, that almost like chin jut, forward head and really tight suboccipital, over compressed suboccipital area, just because when they rack squat, they if they squeeze their scapulas together, it automatically shoves their head forward.
Right.
And it makes their clavicles raise up. And so that gets all pulled in there. So but his stuff was just mostly low back underneath, and not, because I've seen people with headaches and dizziness and all kinds of weird things from this, because they're just like got that head in that position. But it's interesting laying on the back if it's a strategy that he uses for a lot of stuff, or it's just a movement pattern that's stuck. He employed it laying down when he really wouldn't need to do that.
Right, right. And
It's not
it's almost like
necessary when you're laying down to like have to work those muscles like that.
no,
Yeah.
no, exactly. And all the posterior muscles, so he's jamming his elbows down.
Mm-hmm.
But what I'm noticing here, he also had the issue of an acid reflux that would be more thorax, but he told me that his upper back would get fatigued after an asthma attack, which I guess makes sense, right?
Mm-hmm.
So when I gave him the decompression, he was like, "Oh, I can't believe this." So I wanted to just mention that for the listeners to understand, because if someone says they're really stiff and you don't think that they are, try to correct their driver and see if it makes a difference in their flexibility. It may or may not.
Mm-hmm.
But
Mm-hmm.
this guy's strategy, he automatically had a gripping pattern that affected the length tension relationship of the hamstrings onto the pelvis into the thorax. And so let's sort of, we can move on from there. He didn't have any imaging, and he was okay with that. He had a few allergies. I'm just looking through his sort of history here, but it was mostly, for me, the asthma was a big thing, okay, which
Yeah.
sort of drove me to the thorax. And the
Mm-hmm.
low back pain's been going on for so long. So with him and with many people, I want to talk about how do you position and how do you teach these people not, or Shirley Sarman would say, just don't do that, right? But it's like you want it. These people need to be trained out of this pattern. Yes, he needs to do that when he squats, the rack squat. You have to have that, but he needs choices for movements. And so I'll tell you a couple of things I gave him, Susan, and then you can sort of,
Sure.
I did some hands-on, but I really want to talk about the exercise progression. Two things. I had him lie on, I did this purposely, had him lie on a half foam roller instead of going this flat on the ground, because I didn't want his low back or his thoracic spine to get that feedback of the table. So I
Mm-hmm.
just had him go on the half foam roller, take those little orange Franklin balls or a bottle of water, and literally do just both together, like hugging a ball, scap protraction. And then I gave him the cue to slowly let his shoulders relax versus jamming them back into the table.
Mm-hmm.
So I had
Mm-hmm.
him do some scap protraction, hug a tree with the cue, float your shoulder blades, and then let him relax. And so that was one thing I gave him from the get-go.
Mm-hmm.
And then I also gave him a kneeling wall squat. So I had him face the wall on as he was on, because I just wanted to make sure that foot wasn't a player, and I just didn't want his center of mass to be completely off because he was very much to the left in standing.
Mm-hmm.
So I had him go on his knees, put his hands on the wall, and just like do a bow, like you're
Mm-hmm.
facing the wall, hands above, probably about 100, a little bit above shoulder height, and then you're just doing a squat, because he had a problem with the squat, right?
Mm-hmm.
But so that's what I gave him, to sort of disassociate the scapula off of the thorax. So I gave him like a movement piece, like I don't know, a release, I guess, piece, and then I
Mm-hmm.
gave him a scap protraction. I'd love your thoughts on that to start.
Yeah, a couple of thoughts. I love the idea of putting people like that on a foam roller. I assume you put the foam roller longitudinal along the
Oh,
spine,
yes, yes.
just for people to kind of understand and just to they can't grip when they do that because they'll fall off the foam roller. So it makes them use different strategies. And it sounds like he needed a little bit of an ab strategy to help him feel stable in order to bring his arms into that hug position and bring them down, let the scapulas kind of just be movable on the thorax. But he still had to maintain his body position in that way. I'm just kind of wondering what his right foot looked like when he was lying on
So
the foam roller with his feet on the ground, feet
it
on the
was in his.
bed.
So I will tell you a story. So it was in his external rotation.
Yeah,
Right.
yeah.
Yeah.
Mm-hmm.
Yeah. So in standing, when I first saw him, I said, okay, I'm just going to rule the foot in or out. So, let me tell you, uh, so I just basically had him take the weight on his left foot. I said, give me your right heel. I did a little bit of distraction, subtalar joint, and a few other things. But for the purposes of this episode, we'll just say I sort of helped neutralize that foot. I had him pick the left leg up and put it down. I stepped back, and then I looked. And I was like, holy moly, his thorax, his head was so far to the left, it
Mm-hmm.
made it worse.
Yeah.
And I said, okay, that I need to check for another day. He just could not adapt. His body could not adapt to that.
Yeah, too much. But that's interesting. So he had to employ a kind of a external rotation pattern at his hip in order to stay on the foam rollers. So, they will do that, but that, getting them to where they can't use their typical strategy, particularly if it carries over into other movements that it doesn't really need to be their part of, like an Iraq squat, he needs it, but he doesn't need it to lay on the bed and move his arms. You don't need to have that type of strategy, but it probably fed into making him stabilize a little bit, more in the front than using a back strategy, the posterior chain strategies, and get an anterior chain when going. I like that. I also like the wall squat. And for somebody like this, one of my favorite things to do is to have them grab a hold of like the kitchen sink, or the countertop or whatever, and do a walk back so that they walk all the way back to where they're at 90 degrees at their hips. And then just have them, work their kind of, can you drop your scapulas? Can you wing them? Can you lift your shoulders up? Can you go back? But just to give them to really challenge that, can they drop their head down? Most of the time they'll keep their head straight up, and it's like bring your nose down towards the floor, so that we're in more neutral position. And one of the things that I think also is very telling for this is that hands and knees. When they get on hands and knees, if they employ that particular strategy, they have great difficulty dropping their head. They really they go to sit back, that head comes way back with them, and it's not really a neural tension thing. It's much more of a strategy thing. So really getting them to like open that's the one time in that position I really want the thorax to move more than I want the lumbar spine to move. It's like, we're going to keep the lumbar spine and pelvis still. We're going to move the thorax so that they have to, actually round that thorax up and like protract and drop, and drop their head a bit, and, just to help them shift and get out of those positions, because he needs that. He needs to have hands, closed chain, hands-on work, which is why I love that you did him in half kneeling on the wall, because if he's going to do work on a pole, his upper extremities actually become his base of support.
Yeah, exactly. I like what you said earlier about abdominals. How do you expect someone to get bilateral, both of their legs above their head, or flipping on the pole without an abdominal strategy? His gripping strategy put his abdominals in an inefficient position. They weren't even firing. So I like that you brought that up. So because he's not inflexible. The lay person will say, well, I can't get my legs if I feel really tight. Not always the case. It could be a dysynergistic movement pattern, which was definitely his case. I like the sink thing. That's almost like a down dog, but you're not bending your knees, and you're really doing a nice disassociation, and then you're moving your shoulders and your head. So
for him, it would be meaningful because that would show him that his hamstrings aren't tight.
Yes.
Because if you can get to 90 in that position or even more, then it's kind of, so that's where maybe even the Pilates thing where you I guess you could go inverted and put your hands on the pedals. I can't remember the name of the Pilates thing. It's the chair. Is it
on the reformer? Oh, the chair. Yeah.
So you could
like a pike.
Yeah.
Yes.
For somebody like that to help them really change that strategy in an upside down position that could mimic some of his work that he does. For those of you who don't have anything like that, one of the things that I do is I would have them, it's a strategy I used when I was learning how to invert. And to begin with, I laid on the, so it's the bench in the gym. And I basically laid my belly on the bench and put my hands on the floor. And then from there, I worked on being able to drop my head and completely invert. So because I couldn't do it from a much higher position, I just didn't have the strength and I didn't have the balance. And so something like that could work for him. He would be able to even be on his knees on the bench. And be able to, roll down, towards the floor and come back up. And he would not be able to use that strategy because he would not be able to round himself down
Yeah.
to
So you're
get to
saying
the floor.
on a weight bench.
Yeah, like a
Yeah. Yeah.
regular weight bench, just
Mhm.
put both knees on it and just fold your knees and sit on your sit on your legs,
Yes.
like like
Yep.
that. Like so it's like the wall squat
Mm-hmm,
on his
mm-hmm.
knees. It's going
Yeah.
into the
Yeah.
same position, but instead of going away from going back from the wall with the hands on the wall, he has to actually actively flex the thorax
Yes. Yes.
to get his hands
Yes.
down to the ground and drop his
Yes.
head.
Great
And
idea.
so so those are some things that I think could
Yeah.
work really, really well too.
Yeah. Because he's in the gym. He definitely
Yeah.
goes.
And those are, maybe for a lot of people that may not be a meaningful activity, but if they're working on, if he uses that strategy in a deadlift, that's darn sure something I would do.
Yeah.
You
Yeah.
know,
And
if he's like trying to, do the deadlift by employing that strategy and bringing his head up and squeezing his shoulder blades together,
yeah.
I definitely would use that bench activity to teach him how to, that
Yeah.
this is what we want you to do. We want the head down. We want you to round
Yeah.
over.
Yeah, yeah, I like that, and I gave him something like with the prones, like we call it the pike on the Pilates chair. You can have, you can just have somebody lean over, put their hands on a chair, and just push down into the chair,
Yeah.
round and lift their
Mm-hmm.
heels. So that's another option. But if they're going, he's in the gym, so you want to make it easy for him. So I like that. I like the weight bench idea as well. So,
Mm-hmm.
and I think this is a very common pattern that you see among not just weightlifters, but of the many people who sit a lot for a living. I'm supposed to sit up straight, Erica and Susan. I need to sit up straight. I'm going to jam my shoulder blades back. That's kind of not how you sit all day, right? And so it's very common that we see
Mm-hmm.
this, right?
Mm-hmm.
So moving along. So with him, the abdominal synergy was key because he had been hurting himself after pole dancing.
Mm-hmm.
But it was mostly the rack squat, right? But after the second visit or the third visit, I think he went pole dancing, and he's like, I actually felt pretty good, because he was very, very compliant with what I was
Mm-hmm.
telling him, which is a shocker for some people. They just don't do it often enough, right? And I just trying to tell him that we're trying to rebuild new brain maps. So what I did, so going back to your hands and knees, I did have him on I did that in the clinic. So I did him on his hands and knees, a great way to disassociate, him going into a round back. So I said to him, I said, you have a problem with, you said you were doing glute kickbacks in the gym, right? So ultimately, let's just try that if that's something that you want to go back to.
Mm-hmm.
So I had him really I said, pretend there's a big ball underneath your chest and you're sort of rounding your back. I want rounding your thorax, and I just want you to, I don't even want you to do a glute kick. I just want you to keep your foot on the ground and just extend your leg back, almost like on all fours, but the hands aren't moving and they're in a round back position. And he did that pretty okay on his left. On his right, he had a harder time. So that's something I did give him as well. And the second visit, sort of more of like all fours, in that round back position, just moving his legs a little bit, because the glute kickbacks are something he does. And he has not done that because of his symptoms. So I did do that. And I also I like to do some sort of, I do some hands-on release in that position. And so for the listeners, I'm going to skip over that, but I just did some serratus work, in that active movement positioning as well. So
yeah, did you do anything around the diaphragm? Because with asthma
yes.
and the stiff thorax, I'm going to remind everybody of what we know about the diaphragm, that he has pain, so there's part of that. But before there was ever pain, this asthma, this movement strategy that he has may have been adapted from trying to breathe with his asthma. Forward head, pull your shoulders back to try to open the airway and get it in. And the diaphragm is probably in these positions chronically become skewed. So it's flatter, and it's, the crust is pulled back towards the spine more, and the breathing isn't as efficient. And it's just something that the body does in the when it really is struggling to breathe. It kind of makes it harder to breathe, which is like really interesting. But they're struggling so much that they just adopt these postures, and they don't have to be like gasping for air. When I'm talking about struggling, it's like if there's tension in the lungs, the musculoskeletal system is going to overwork. Even if it's overworking slightly, it's overworking, and that's a lot of time during the day or 3 days or, whatever it may be. And then the lungs get stiff and the system has to continually work just a little bit harder until, we adapt until we can't.
Yeah, and that fits with his story about his upper back was fatigued and sore after he had an asthma attack. That's
Mhm.
fits perfectly with that.
Yeah.
I think that's great because um, I would agree. We talk about the timeline. He doesn't. He's young, right? He's in his late 20s, early 30s, right? His first, like when I said to him, "What's your sort of first injury or anything?" He's like, "Oh, I don't really have any, but I've had asthma since a child," and that was the first thing that came out of his mouth.
Hmm.
And him snapping my fingers here, but that's relevant. Okay. That is over 10 years ago, 15 years
Hmm.
ago. And the strategies you just talked about, they adapt to that. And so the diaphragm work is I'm doing a lot more of that lately. Actually, I think that's a great idea.
Hmm.
So
Yeah. So my
you,
favorite go-to thing with
you
this
go
is
ahead.
because when they have this type of movement strategy, they have almost an upward swing of their thorax.
Yes.
It swings anterior and upward,
Yep.
and they don't have an efficient ab strategy. They usually don't. And so really by helping them kind of just, with the rib work that you're doing and stuff, you can actually help them bring that thorax and balance it over the pelvis a little bit better. And then
Mm-hmm.
I teach them how to use their abs on an exhale. And then I have them keep their abs in that little bit of tension after exhale while they inhale. So it forces the
Ah,
diaphragm to actually, work. And
mm-hmm.
they've got the tension from underneath in the abs so that there's something for the system to work with. Otherwise, they're just going to go right back to the other way. They're going to just
That
pull back
bracing.
into it. Yeah.
Yes.
So that's kind of an interesting way to, get the diaphragm moving in a different, under a different circumstance by just slightly increasing the pressure of the belly and decreasing
On
the
hands and
thoracic
knees.
tension. Yeah, just to
Yeah.
see if you
Yeah.
can get
Yeah.
that diaphragm to those lower ribs to expand while the belly
Yep. Yep.
maintains. It's not a huge tension, it's just enough tension
Enough.
that they
Right.
can do on exhale to just hold that while they breathe in. And
Mm-hmm.
that's basically what Pilates is based on, is like
Yes. Yes.
using the the abdominal canister to
Mm-hmm.
to stabilize and the ribs really expanding and moving.
Yes.
That's
Yes.
that's how he rolled. So
Yeah. And I mean, I do have access to Pilates equipment, and I did use the chair and I've used the Cadillac, but he is in the gym. And so
yeah.
I'm trying to do things that he can do in the gym as well. And so, I love that diaphragm work, and I have to do more of that. And I think that because he's made pretty good progress, it's just, I can't simulate a 225-pound rack squat in my office,
Hmm.
so I'm going to have to just, the strategy's there no matter what he's doing. It's just that it's not just fun. I was telling him, I said, look, everybody has issues in our systems, in our bodies. It's just, we adapt and we can compensate depending on our level, right? Sometimes, your driver is there, it's not dysfunctional enough to cause you problems. Yours is sort of comes on when you load your system and you're in this bracing strategy. And so that's why other activities for you, pole dancing, yes, it bothered you, but the squat was worse. And so I think he understood that, and he was very, very much of a compliant patient. And so I'm just going to move along. I needed to get him to rotation, and so this is where I want to sort of finish up. I ended up giving him, I did a few other things. I actually had him go, two things. I had him go on the wall. So I had him face the wall. And I talked about this before, we have on the podcast, wall lands so you're staying about 3 feet away from the wall. You raise your arms way, not behind you, but sort of above your head. And then you land on the wall in that
Hmm.
scap protraction, but you're not going into deep retraction. And so I had him do that. And it was really hard for him, really hard, really hard. I'm emphasizing this because he's really, it could tell thinking about, he just doesn't want to go into that little mini push-up because he's afraid he's to retract. I'm like, that's kind of supposed to happen when you do a push-up, but I need you to come from a place of uh, of how can I say this, of a position where you are just associating your shoulder blades from your ribs versus starting in a position of squeezing your shoulder blades and then going down. You need to be in a more open position. I'm demonstrating with my hands here, and so he understood that. Does that make sense? Am I explaining that right?
Mm-hmm.
Yeah.
Yeah.
So
Yeah.
yeah,
So
because
you,
I didn't want him to retract and then retract. I want him to open, protract, and then retract.
uh-huh. Yep. So that
Yeah.
he would
So
have to employ a different movement pattern to be able to hold his body against the wall.
right. And I said to him,
Mhm.
I said, when you go down to a push-up, your shoulder blades are going to move together. That's sort of supposed to happen. It's just that you really it's not the prime mover, right? And so I wanted to look at rotation. So in basic seated thoracic rotation, we did an episode a while ago when we talked about the cervical ocular reflex. It was a
Mhm.
while ago. We talk about it a lot. But I said to him, I said, just sit on the plank, turn your put your hands across your chest and turn. And his rotation was fairly good. So I said, just use your, and I did notice a couple of things. So his left rotation was fine. He got about, I would say, halfway, and then he started to take the elbow and dump that right shoulder blade back into that retraction in rotation right. I said, just take your eyes, just use, I want your eyes to follow your rotation, your thorax. He did that, and his strategy was much better. Not 100%, but it was a lot better. And so I
Mhm.
think not fail, we forget sometimes about the eye position in rotation. I know we've
Yeah.
talked about it a lot.
Which
So
goes into that whole chin forward,
yeah,
suboccipital extended posture into,
yeah,
into extension. He probably was doing it more on one side than the other. And
yeah,
so, the eyes fail to track because they're only going where the head's going to go.
right.
And yeah, it's something else with people like that. It's very interesting because when they have that chin that's jutted forward and that bit of forward head, their eye gaze is always down. And so when you get them
Mm,
lined up, they have a lot of trouble raising their eyes up.
yeah,
Like, so that's why I like the
interesting.
clockwork on the wall, because if you
Yeah,
get them
yeah,
straight and you can get them to where they're in a neutral position, they have a lot of trouble with the upper quadrants of their eye movements because they're used to looking down because their chin is forward.
yes,
And
yes.
of course that happens to people all the time with readers,
Yeah.
eyeglass
No, I know. I
readers.
do it. Yeah.
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 And so this is why I'm always, especially if he sits for a living, I would be all over him to get a pair of glasses refracted to his screen.
Yeah,
And,
that's a good idea.
just so that he won't do that.
Yeah. Yeah.
Whatever that
That's a
is
good
that
idea.
he's doing. Yeah. Just, it'd be interesting to see because there's all kinds of things that'll feed into that, the
Yeah.
asthma and who knows,
Yeah.
everything. It's
Yeah.
like
Yeah.
you got to kind of dig it all out of there,
Yeah.
when you're
And I
really trying
think
to reset a dominant pattern. Mm-hmm.
and I think that's the key here is because he complained of low back pain. And, for the listeners, we know if someone has had persistent low back pain for years, chances are high that it's not their main driver, right? They've adapted
Mm-hmm.
and they've adopted and adapted and changed and compensated. And that's why you go back to the history. And in my opinion, the thorax is big with him because of the asthma, and it's big in many patients as one of the main drivers. And so for rotation, a couple things, I'll just sort of progress with the scap, the original exercise I gave when you're on the half foam roller vertically, you can progress that. So what you can do is you can do single. If you do like a right arm protraction, that goes into, you go into thoracic left rotation, right? You do left arm protraction, you're going into right thoracic rotation. So you can progress that, right? You can do you can do that. And so that was sort of a progression for him. I kept the on their his hands and knees fair, in that sort of round back position, kicking the legs back fairly early, fairly long period.
Mm-hmm.
And then since he's in the gym, this is what I ended up giving him. So I had him. I'm trying to explain this. His back is too low. So a TheraBand is tied around, let's say, a ladder or something. You are facing away, so your back is to the TheraBand. Okay,
Mm-hmm.
the band, you've got one band, one end of the band in one hand, another end of the band in the other hand. So I started him that way.
Mm-hmm.
So he's facing away. So I have a fuse ladder where I am. So I just wrapped the band around the fuse ladder. We turned him around, and then I put him in a split stance position because I wouldn't have started him there. I would have started him with the squat, but he was pretty much well on at that point. So I had him in a split squat, left leg forward, right leg back. I had him literally sort of, I had his arms in front. Now they're in front versus the rack squat where they would be in the back. So his arms were in front. He's pulling on the band. He's just doing basic skull crushers, bilateral together in that split position. I had him switch his feet, right leg in front, left leg back, repeated bilateral skull crushers. Okay, in front. And then I'll just, one more thing, and then I'll get your thoughts. Then a progression for that would be same position with the feet, left in front, then right in front. I had him alternate. So you're getting that rotation in the upper body on a split stance position. And his gaze and his nervous system, his patterning is in the front. So
yeah.
I'll let you have
yeah, no, I think that's great. I love it. The adaptation for that for somebody that if it really was a big foot driver would be in half kneeling. Maybe start off in tall kneeling if you're trying to get an ab strategy going. So that they have to, because they have to use their abs in that position to do that. And then move it to half kneeling, and then to stance and split squat. You can kind of work them through whatever stage and area you want to work through.
And you can keep that exercise plus the one on the half foam roller in the program for a while. You can just change it up. I mean, add weights, go on a full foam roller. I mean, I think we just have to clinically reason why we're doing this. And I'm doing this is because I need to get I need to down train his dominant pattern of that scap retraction, that bracing. He does need it when he puts a huge weight on his back, but he needs to be able to get himself out of that pattern. I think that's where the rubber met the road, because it was a pattern he did all of the time. And so when he does exercises or movements that force him to use other strategies, that's sort of the overarching theme of the program. You're forcing your patient to use a strategy that they're not using. And your creativity is your limit, is really your limit here at this point, because I can justify in front of his body. Do I eventually need him to go to a wall land and pull? Yeah, I do. He needs to do that, but he needs to be able to choose a strategy based on the requirements of movement. And what he was doing, he was choosing the same one for everything. And so I'm actually still treating him, but he's a lot better. But you're going to see patients who have hip pain or who have neck pain or shoulder pain, and they're going to have this strategy. And I think you're going to have to, figure it out for your clinical reasoning process if this strategy is relevant. Right, Susan?
Yeah, 100%.
Yeah, and I think especially with weightlifters, they're taught to dump and retract, and so you can keep exercises in the program, just progress them, and just make sure that you talk about the history. Just make sure you go back far enough in the history, because every single thing pointed to the thorax with him. Upper back fatigue after an asthma attack. He doesn't do any upper body exercises. He had one issue of an insidious onset of low back pain, right? And it came on with specific movement patterns using arms. He was using his arms. Every time his back went on was when he was using his arms, when he was using his arms on the pole. And so is there a control pattern or a loss of control in his upper extremity? Absolutely. So that's sort of where we need to go.
Yep.
I think
yeah, I think this was great to just kind of, unpack this and talk about it. I think even one more step for people who are keeping people in the gym, which they should, is that if he's going to do a rack squat, then he needs to have another exercise afterwards that's going to take him out of that position. That's like almost a reset exercise almost immediately, till he can do it, and even work resets into his pole. His pole choreography. Like if something really requires that type of strategy, let's be sure that there's something that you can do right after in your choreography that will remind you to pull yourself out of that, kind of thinking along those lines, with performance. All right, this was great.
It's fun. I don't treat many sort of part-time pole dancers, so this was kind of cool. As always, thank you for listening, and we will look forward to speaking with you in our next episode.
Yes, thank you, everybody.